Hall. And here with us are Jim Pizzo, Todd Fitz, and Dr. Robert Pryor from Kaufman Hall's Physician Advisory Team. Today's speakers draw on decades of experience working with and advising medical staffs and health systems. Today, they will be sharing their insight on physician compensation under value-based payment. Before we get into the presentation, I'd like to quickly review a few housekeeping items. Whether you're listening through your computer or via the conference line, all attendees will be in listen-only mode. If you are participating through your computer, you can send questions to us through the questions pane on your attendee interface. Simply type in your question and click send. At the end of the presentation, we will answer as many questions as we have time for. If your question is not addressed during the Q&A, we will be sure to follow up with you. Please note that material related to the issues we will be covering today, including the presentation, is available and accessible within the handouts area of the attendee interface. On a final note, today's webinar is being recorded, and everyone will receive an email within 24 hours with a link to view the recording. Any of your colleagues who registered for the webinar but were not able to attend will also receive the link to the recording, and the recording will be posted in the events section of kaufmanhall.com as well as an on-demand webinar. With that, I will turn it over to Todd Fitz.
Great. Thank you, Rob, and hello to everyone. Good morning or good afternoon, depending on where you're at. We're all excited here to have this conversation. It's just one of the many areas that is very dynamic and challenging given everything that's going on in healthcare. And we found it pretty interesting given we've talked about physician compensation a number of times over the years in webinars and conferences, that for this iteration of the conversation oriented around value-based care of attendees, and the interest in this one was significantly higher. And I think that speaks to the challenges we're all facing, and in some ways some of the reverberations of macro in particular, as we've heard that in many conversations lately, and in trying to understand that, and we'll address that a little bit today. So, to start, we're going to talk a little bit about some of these bigger trends. We won't spend a lot of time here, but I think it's important to acknowledge some of those trends and the implications before we get into some of the specifics of compensation planning. But as we've looked at compensation planning, this is just another evolution in something that's been changing over time, and changing in ways that becomes more and more complicated. Obviously, early on, physician compensation was very much driven by the direct financials. The more money you generated, the more compensation, and that could be directly tied. And over time, we've gone from productivity-based approaches to increasingly approaches that bring in some of these other variables that apply to value-based care. And the question, and one of the things we'll explore today, is what does that look like? What do we expect it to look like? And how do you continue to plan for it and succeed as you deal with this transition and evolution of the market? So this is not easy, I think, is the simple way to put it. When we think about the balance that we're facing as it relates to trying to change how we compensate and incentivize physicians, we're doing it in a way that has to balance the achieving and incentivizing what we're trying to accomplish, in the context of it's still very difficult, particularly in certain areas, to recruit and retain physicians. As we employ more and more doctors within our organization, the financial challenges and in creating a sustainable physician enterprise becomes more challenging. And so this idea of compensation, obviously the biggest expense in the physician enterprise, is one that most organizations should be spending a lot of time thinking about and continually improving over time. So on page 5, is really just conceptually what we're talking about, as it relates to this evolution of moving from value-based care, from productivity-based compensation to value-based care. And one of the things that I think is most important to note on this slide is we're still very much in the beginning stages of this. We'll show in a second that most organizations, while they've started to introduce these ideas into their compensation methodologies, they've done it in relatively minor degrees to this point. The other key point here you'll notice is that sort of slanted line doesn't go all the way to zero on the other end. And that's sort of speaking to the idea that we don't believe that productivity will ever go away as part of compensation planning. We think that you're still going to want to have productive physicians, but that's going to be just one part of a total compensation approach, that eventually will be weighted more towards other factors, quality, access, and service, but never losing sight of productivity as well. Next page on 6, the drivers of this and the march forward now seems to be a given. We still hear once in a while some hope that, whether it's an election or some other event, that some of these things will be rolled back or the trajectory is going to be changed significantly. But I think for most of us, and especially the leading organizations, we're pushing forward and we're planning for this because we see it. We see it all on all fronts, not just the government payers, but also the private payers, and even some of the providers themselves. And so there may be a few of you on the phone, part of the Healthcare Transformation Task Force, but these are organizations that are already finding a way to get competitive advantage, to drive financial benefit by pushing their markets and everything associated with them further and faster into value. So I think this is a train that's left the station. What we're trying to do now is understand how do we best manage it within our organizations, given all of our markets are different, and how we might want to approach this is very different. And so I just said that the markets are different. So on page 7, this kind of gives you a sense, and you'll see pretty quickly these are actual compensation approaches for particular markets where we've been involved. And you can see that by and large, while there is an introduction of value metrics into their compensation plans, for most of these markets, they remain in the relatively low percentages, 5, 10, 15% allocation to value. You'll notice, though, in particular places like California or Minnesota that are much more progressive as it relates to population health management in the most generic definition. You see the value percentages are increasing proportions of the compensation there, and probably speak to where the rest of the country is going to move in the relatively near future. And I think we're having a little bit of lag with some of the slides, so we apologize, but we'll work on getting caught up as soon as we can. So the last page here and kind of the overview before I hand over to Jim is, some of the questions that we'll get to today and the rest of the conversation, and probably some things that are on your mind in terms of, how do you start to introduce this or expand the role of value-based compensation within the physician enterprise? A big question that a lot of organizations are struggling with, not just specific to the compensation, but overall, is the role of technology and how we apply those tools, and how we even keep up with those tools as they evolve, and we have increasing numbers of them and interfaces and data coming every which way. How do we make sure that that data is timely and accurate and applicable to what we're trying to do? And then the last point I'll sort of emphasize here is how do we engage physicians in this process, both compensation planning and our evolution, because it is fundamental. And as we've worked with organizations, those that are better at engaging those physicians in the process, in many ways letting them lead, are the ones that are finding more success as they move forward.
Okay,
So
Jim, in here.
I will let you.
If we could move on to page 10, please. The first comment I'll make is a comment about just what we're looking at and what we're referencing here. When we talk about employed physicians, it can be employed by health systems. It can also be the large independent multi-specialty groups, because we're working with a number of them now, but the issues are the same regardless of the setting, because both sides are really looking at how they make this leap towards value, and they're also looking at how can they do this in a fiscally responsible way where they can adequately compensate their physicians and keep them engaged and aligned. So as you begin the discussion on value, one of the first things you really have to start to put some stakes on the ground on is, how are you defining value? What are the things that contribute to value? And, how are you going to make that migration or evolution to value? So there's a number of different ways you can look at it. And the purpose of 10 is to really just show you these are different things that many clients build in. Some build in certain aspects of these and not others. Some try to build in a more comprehensive value matrix to align and incentivize physicians. But you have to really determine, based on where you are today as an organization, which of these can help you make that movement in the smoothest, most efficient manner. Because one of the things we as a firm know is that if you're disruptive to physician compensation, you're probably not going to reach the goals that you're setting for yourself as an organization. So you have to make sure that you do it in a well-defined and smooth manner. On 11, and this is just meant to highlight some of the key things we're typically looking at, and Todd went through how we've made that pivot from more productivity based into a limited set of quality access and service depending upon the market. But the one observation is we have a number of clients we've worked with in Southern California and Minneapolis and some of the other advanced markets that moved away from productivity. And at first it appeared a good thing, but then as access decreased, so did patient satisfaction. And for all of them, within a year, they were back into having some key productivity measure that improved access and kept the right moderation between focus on productivity and quality access and service. Another thing we've learned as you begin to look at these is you can't make all the metrics at the individual physician level if you want to change group behavior. So you have to look at individual level performance metrics, specialty performance metrics, site, and group as a whole, because you want this group to operate seamlessly. And what you want to do is not build silos of metrics, but build metrics across the silos. And transparency is always, when we do our guiding principles, transparency and simplicity are always up there in terms of we want this to be something people can view on a continual basis and understand. If it's too complicated or it's not transparent, it will not be sustainable or successful. Todd had mentioned technology, but one of the challenges for us as an industry is how do we take all this data and create information? And so that's really, we'll look at a number of ways to do that, and that's very important when building the metrics to make sure that you've got good longitudinal data that's reliable. And then how do you tie all of this data that you're going to use to develop your comp plan into your monthly or weekly reporting, benchmarking, dashboarding, because it has to be accessible, be able to be measured, and be able to look across your enterprise as a whole so the physicians have comfort that their individual performance is tracking. Moving on to page 12, we're an industry of acronyms, so what we always drive towards is MPR, measure, publish, then reward. And to measure, we don't look at what is the perfect metric in the long run. What we say is, based upon the data that you have, what is reliable information that can be longitudinally produced and accessed on a timely basis for physicians and leadership of the organization to align their behavior. So the first key thing is you say, what can you reliably produce? And then if there is a gap between what is the best data to look at and what's available, is you try to have a 2 to 3 year plan in place to migrate towards being able to capture and measure that data. But the worst thing you can do is adopt a metric that isn't reliable. In the short term, you lose credibility with the physicians, and the law of unintended results is you probably aren't going to get the behavior you want. Publish, and this can be a challenge many places. At some of the leading organizations, by site, by specialty, all individual physician information is now published in the physician lounges or sent out as a matter, monthly reporting or weekly reporting, and it's unblinded. The individual physicians' names are listed. When you first begin this migration, you may do it where it's blinded, and only the individual physician who gets it knows what his or her metric is, and the rest are blinded. But you have to begin to allow physicians to sort through the data and see how they perform relative to their peers. And you might want to also put in market data in addition to your individual physician data, or long-term targets, so that they can see where they need to go, how they're doing, and begin to make that incremental change that's needed. And the final is the compensation system has to reflect it, and it has to reflect it in a timely basis. If you disconnect the rewards from a time perspective over too long of a period of time, you're not going to see the level of alignment you want. So it has to be able to flow through in a timely manner. Page 13 really is just representing, this is right now where most organizations are, where about 85% of it is still clinically based on productivity. And then the other 15% is really more on quality. We'll go through this a little later, but that can be by specialty, by site, a number of different ways. Service excellence, which includes patient satisfaction, referring physician satisfaction, all the different service metrics you can bring in, as well as access. And I know it's an industry challenge, what's our best data point for access, but sometimes it's as easy as just setting the standard for same day for certain primary care specialists, next day or 3 days for a procedural specialist. But this is an area we work on quite a bit, determining what's the best way to measure it, given that historically as an industry we don't have good metrics in this area. And the final bullet point down there is strategic initiatives. And these can be things that the health systems or the large multi-specialty practice say, what do we need to do? If we need to set a new site out there, it's not going to be fair to hold that physician accountable in the first year to maintain volumes that we need as a group or as a system. Or if we want to open up a new program, or if we have to go into a specialty where we'll have to contract or hire 3 physicians to get the call coverage, you have to make accommodations to support compensation if you're asking those physicians to support your organizational strategy. And so we will build that in so that it does align their behavior with system or clinic goals. On page 14, and this is something that you can plot out for your own organizations, and you can move that red curve. But when you plot out productivity versus the combined index score for quality, access, and service, at some point in time, you do have to set boundaries about what's acceptable for quality, access, and service, and what's the minimal acceptable for productivity. So when we look at these axes over the long term, they wouldn't start at 0. They may start at median productivity, or they may start at 40% productivity. And for quality, they may start at the 60th percentile or the 70th percentile. So they're not absolute, but what you want to do is look at where the physicians within your organization or clinic perform and try to determine at what point in time do they not meet threshold levels for either productivity or quality, access, and service, and then work with them to move it up. But one of the challenges for all organizations in the future is how long can you carry physicians who don't meet organizational objectives? And it really is causing quite a few comments as well as discussions, because sometimes there's the best intentions, but if you can't meet certain threshold performance levels, like all industries or like some of the high-performing large independent clinics out there, you just may not be positioned well for that organization in the long term. And it's a simple way to plot this out, but it's a good way to begin looking at it and then working with your physicians to get them where they need to be within these bounds. On 15, and I've talked about this already a little bit, but when we look at what are the metrics you want to reward off of, you have to, or you should have, a balance of individual metrics and team metrics. What you want to avoid is setting such a focus on individual metrics that you don't have the physicians working with each other within specialties or across specialties or within sites. So you have to build in some of those team metrics that are on the right as well. And these are just high-level things that we look at. When we work with organizations out there, there are multiple different measures you can use for all of these. And the real key is what are the right measures for your organization in terms of what data can be mined, what can be measured, and what can be reported on. So what we aren't going to do here is put together a checklist of here's the things you should have, But later we'll go through when Dr. Pryor presents and touch on here are some of the typical areas you want to have metrics in. But again, it should be customized to not only your individual organization, but also to your market and where your market lies in its evolution towards value. Moving on to page 16 here. If we look at one of the other challenges out there as we've made the transition to value is how do you develop alignment between primary care and specialty when a number of the incentive programs that payers have put out specifically reward the primary care physicians incentives to reduce specialty utilization, sometimes appropriately, sometimes maybe not necessarily as appropriate. So should internal medicine be doing the front end of cardiology to reduce cardiology utilization? At what point in time do you get the patient in to see the orthopedic or neurosurgeon for a back problem? But a lot of these incentives, if you don't balance them at the group level, can create silos within your physician organization, whether you're an independent organization or a large employed group within a system. And so as we're working with clients, one of the things they're looking at is how should they bring incentives into a pool level for the whole group, and what proportion of those incentives should stay at the individual physician level. But the key goal here is to get alignment, and it's to get the specialists involved in understanding that, as they will also be rewarded for, the value that they can produce, and not just along the productivity that they will drive. And again, these are tough issues, and when you look at the payer metrics, many of the payer metrics have intentionally set, the primaries against the specialists. And for you to be successful, if you're a larger health system, to drive quality and to drive costs down within a large hospital or health system, you really need the specialists. So sometimes these programs can work against you. You just have to make sure how you can align the incentives. If we look at the incentives on page 17, and again, you have to look at it in the context of your local market and your payer contracts, but what incentives should be at the specialty level, whether it be primary care or any procedural specialists, cognitive specialties. Where do you put the incentives in, and should they be individual specialty or cross-specialty? What do you do on a site basis? Because for some larger health systems or some larger clinics, there may be some inner city patients they serve, there could be urban, suburban, and there could potentially be some regional outreach and rural. And should everyone have the same metrics and the same incentives? When we look at how you align physicians and advanced practice providers or mid-levels, one of the challenges there is how do you create a team environment? In the historical model, many times the mid-levels or APPs are incentivized purely for productivity, and in a way they actually compete with the physicians. So how do you get the alignment that everyone is operating at the top of their license? So that's a challenge and needs to be looked at when you set your incentives, both within your contracts as well as within your compensation architecture. And then even extending that to how can you incentivize physicians to make better uses of nurses and other clinicians who can help drive costs down, quality up, et cetera. So multiple levels of incentives are needed. It's not just incentives directly related to that individual physician's performance. Now, a lot of discussion goes into what metrics to do, but when you get to the end of your comp program on page 18, one of the things you have to address is how should you distribute incentives? And even though it sounds like it should be pretty simple, you really want to look at how do you invest in the future and how do you distribute things so that you get the alignment you need and you can get the incentives to the physicians on a timely basis. So the three things you typically look at is how often should you distribute the incentive payments? What level of reinvestment, either back in the clinic or back in the organization, you should retain for either growth, recruitment, whatever it may be, and how do you split it between various providers on the primary care side and the specialty side. Distribution frequency, I think, the clients that I work with in general seem to believe quarterly because it's close enough where the physicians can see the impact they've had, but it's not so often that it requires a huge accounting exercise every month or every 2 weeks. And for those of you who haven't administered a compensation program, it is a lot of work when you go out to calculate and distribute incentives. So, quarterly seems to be the happy medium there. For reinvestment, and should they reinvest, save incentives, in case there's a period where they don't, and so they can defer and subsequently pay out more later, or for recruitment or program development. More and more organizations are saying they shouldn't distribute 100% of it, but they should retain some of it for future strategic objectives, however it's mutually determined between the physician and the leadership. And then the final is that what we went over earlier, but you have to have alignment between primaries and specialists. And if you look at some of the more advanced IPA markets in Southern California, what you'll find is that over time the primaries have really driven most of the profitability of their IPAs off of reduction in specialty utilization, not necessarily in terms of better rates, better quality, or change the way care is delivered. And if you're looking holistically to drive your organization, you really have to attain balance there so that you do get alignment. Otherwise, it's going to be very difficult for you to compete as a health system or a large multi-specialty clinic. Page 19, just a couple quick comments here, but one is there's lots of different surveys out there. There's lots of different data, but number one, make sure the data is timely. Second, look at the data and say, is it relevant to your local market? And that would include going back in and looking at what is the net collection to WRVU in the survey data versus locally, because if you have different payer dynamics, that may mean you're overpaying or underpaying your physician. You might also want to look at sample sizes. And then another thing I'm urging my clients to look at is to really look at what is the differential between employed physician compensation and independent physician compensation. And in many of the surveys, the employed physician compensation, and employed in that definition is health system employed or hospital employed, you'll find that the delta can be 25 to 35% higher for the employed physicians. And what that really reflects is that that is effectively part of the operating loss the health system will have, but the independent physicians, many times in certain specialties and subspecialties, because market reimbursement has gone down, they're actually at what would be more a true level of compensation. So always, if you're looking whether in a clinic or a hospital setting, take a look at what the delta is between employed and independent physicians. And whether you index to net income or net collection, you want to make sure that that survey data is relevant for your local market. So enough there, but surveys, can either enhance or detract from getting the alignment you seek. So just make sure you've got the best available data to use. On page 20, when we start to set targets for incentives, there's 3 different ways you can do if you don't want to always use benchmark data. And to be honest, I've found that these tend to be more successful. Number one is to start setting incentives. Look at internally, what are your best practices? Stratify your organization, see who's where, and set incentives so that you're getting that incremental improvement, and you can demonstrate to the physicians within your organization that, yes, this can be done, and here's how it's done, because you have physicians already performing at that level. Another way is looking at historical indexing. If, as you've grown, you've brought more and more new physicians on, or you've brought it in different markets, go back and look at what some of the metrics that you were achieving in the past were and say, are they relevant today, and are they worthwhile to use when setting incentives or setting targets? So historical indexing also works. And then for organizations that are really leading, if they use benchmark data, it really would say there's nowhere in the future to go. So a lot of the leading organizations, they look at performance and they just say, incrementally, we believe that we should be able to attain a 5% improvement in a number or a 7% improvement, but something that pushes them towards taking their current performance and performing a little better. And interestingly enough, even the people who are at the 90th percentile, many times they are increasing their targets without being able to find benchmark data to support it, just because they know that they can do it and they're going to change the way care is delivered and the cost structure of delivering it. Final thing here, and just to touch on it quickly, is you have to involve physicians in developing the compensation architecture, in setting how it's administered, and in continually reviewing the metrics. You don't set up a comp committee one time to do the plan and then walk away. Continually over the year, you should look at the performance metrics and are they still appropriate, what new ones can be substituted, and what other people out there in the industry are using to say, do we have the best metrics to get the alignment we need? So it's an ongoing role. It's very important, and when the physicians own these decisions, it's actually much more successful typically in implementing and getting the results that you need. So at this point, I'm going to turn it over to Dr. Pryor, and he's going to follow you up through the 3rd section here.
Thanks, Jim. If you'll turn to the first slide, I want to set forth a little bit of context. The first context is that in order for the organization to be financially stable, the money that comes in on value-based contracting payments to the organization cannot over time be significantly less than the money going out. That may sound obvious, but salaries are a major component of the money that's paid out from the organization, and physician salaries are a major component of that. So that's what makes this physician compensation issue so important to organizations. The second thing is, with so many metrics, which are the best to apply to the compensation structure? Everyone looks at their own compensation in terms of equitability, not equality. For instance, a pediatrician does not assume that his salary or her salary is going to be equal to the neurosurgeon. But equitability between internal and external factors is very important. For instance, is my effort equitable to my compensation, which is equitable to the effort that a colleague is putting in, or not? Or the other thing is my compensation equitable to what I thought my compensation should be at this point in my career? The other issue is, how do we deal with the fractional FTE doctor? This is an issue that, since full-time physicians rarely work 40 hours, how do you take and equilibrate a 0.8 FTE to what a 1.0 FTE is doing and keep it equitable? The next is that if you ensure financial stability, first is for the organization, and we touched on money coming into the organization and money coming out. But there's also the financial stability of the physician and their families. For instance, the spouse at home who does the books can't be reliant on a roller coaster ride of how the compensation is coming in over the year. They have to have a certain amount of compensation that they can count on to pay the bills, put food on the table, etc. So when compensation is on a roller coaster and it's up and down, this is not stable for the family. We've already touched on how to engage physicians, and the best way to engage physician is to utilize strong physician leadership with committees that look at what is the clinical relevant data that we're going to use versus what is just a data that's coming in over the transom. There are a lot of published surveys that correlate work RVUs with compensation, but we don't have a lot of publicly available national surveys that have some of the newer metrics that we're going to go to in a minute. And last, it's important for these goals to be specific and upfront, not that comes in later in the year. It needs to draw an array of possibilities that really mean the most to the patient at the end of the day. They have to be accurately measurable. They're best if they're quantitative. They have to be accurately attributed. And a lot of problems that we've had with automated systems that look at the softer side of patient satisfaction and infections, the attribution factor sometimes is not where it should be, especially if you're going to use it for compensation. And the last is that it must be relevant to the organization's mission, vision, and values for the physicians to be really engaged personally into the mission, vision, and values of the organization. So beginning on page 23, you look at the things that we see now, such as clinical productivity, service excellence, access, quality, support of strategic initiatives, administrative duties, on-call and other clinical duties, and overhead expense management. And we've already talked about the importance of accurately getting these up front and correct, and then giving accurate feedback. So timely, accurate feedback given to physicians will almost always result in the physician self-correcting with that accurate, timely feedback. And therefore, the administration of the comp plan, if you can give accurate feedback, is much easier. The next page on 24 looks at some sample metrics that are being relied upon, such as clinical productivity, service excellence, quality, access. And if you look at some of these, they, in generalities, they work well. But when you start getting into specific specialties, such as patient satisfaction, in my career, I once had a division of occupational medicine, and the physicians always said, how do I develop patient satisfaction when everybody I see, I'm going to tell them, no, you don't get disability, or I'm going to tell them, you're a drug addict. So how do I keep satisfaction when I'm giving people bad news? Or alternatively, the primary care physician says, okay, you don't want me to use antibiotics for viral illnesses, but everybody that comes in with a viral illness wants an antibiotic. So which way do you want me to go? Satisfaction or quality of care? So some of these things that we're going to be measuring may or may not be contrary to each other, and we have to be able to reconcile that over time. Access and productivity are almost the same thing, but not quite. We talked earlier about there's the individual productivity that we can measure. You can measure work RVUs very accurately. But access is a broader issue, which is not only individual work RVUs, but it also includes the advanced practice professionals practice that improves access, but has nothing to do with the individual clinical productivity. On the next slide, on 25, we see 4 more sample metrics: the support of strategic initiatives, administrative duties, on-call and other clinical duties, and overhead expense management. Let's just look at administrative duties. When we employ physicians within an organization, oftentimes some of these administrative duties is just taking money out of one pocket and putting it into another. So there's no net increase money for a medical directorship or a CMO salary. These become overhead to the organization, which in tight clinical organizations in a clinic, this overhead has to be paid for by clinical activities and quality activities that come in. The other thing is that with a lot of these new pay-for-value issues, there's a downside to them. So what if you have a 15% hit on a downside that comes from one of your contracts? How do you reconcile that downside risk? But it's not just a bonus, but it's also a downside risk. So these are things that we're going to have to look at carefully. The next slide looks at traditional practice benchmarking metrics. And these are metrics that are used today and can be counted accurately, because work RVUs is generally the physician that does it gets credit for it, unless it's an academic physician and you count some resident work, or a physician with advanced practice professional and you're getting credit for some of that. But this is the case where you look at attending physicians, their specialty, their work RVUs compared to each other, their collections, and then also at the last is appointment lag. The next slide shows some of the newer generation metrics. And this slide is available today. This happens to come from an automated system called Total Benchmark Solutions, which actually has an ability to delve down into the practice, look at accurate attribution, as accurate as can be, and then look at the qualities across the attending physician's practice in a severity-adjusted APR DRG way, looking at cost, looking at ratings, looking at length of stay, risk-adjusted patient safety index, HACs, and it can also look at patient satisfaction and the ability of the physician to even accurately document in the charts the severity of illness. As I said, this type of computer program is available today, and I would suggest that organizations start looking at where their data is today and understanding their data, and allowing the physicians to understand their own data in a timely manner to start self-correcting. Because the other thing is that most of this data is actually available publicly, and other people can get the data, and it's probably not fair to judge a physician on a publicly reported data if they don't have their own data to self-correct. So with that, I'll turn it over for closing thoughts.
Great. Thank you, Dr. Pryor. So hopefully as we've gone through here today, you've heard a couple key themes. We'll try to emphasize a few here and leave some time for questions. You know, I think it's very important to acknowledge that compensation planning and the approach to compensation is something that's going to continue to evolve. We run into organizations and conversations where the organization is trying to have the solution that's going to carry them through for the next 5 years, and the reality is that that's nearly impossible to do, because we don't know how things are going to continue to evolve. We don't know how quickly markets are going to continue to move, and so the idea of growing into this, of matching your pace with and structure the compensation plan with the market is a key idea, and really then necessitates you structuring the process, the compensation committee, as we talked about earlier, in a way with objectives so that they can work under those expectations. Similar to that thought is that there's no one-size-fits-all model. I mean, you can look at what others are doing, and you can find some that are best fit, but what works for a given organization or in a given market doesn't necessarily work in another. And we saw that earlier with some of the clients laid out on the map, just in terms of just at the aggregate level, how much of compensation they're allocating to some of these value-based initiatives. You need to kind of, think about your market, think about the nuances of your organization, think about your position culture, and plan with that end goal in mind, but not think that there's necessarily something that's directly applicable to be taken off the shelf. The limiting factor for most organizations is data, and data availability and data reliability. We touched on the IT piece at the very start. Compensation and performance needs to be metric-driven, and getting those metrics sometimes is challenging. Dr. Pryor just mentioned, one tool and an aggregator that's available that can help get you a lot of the way. But again, having that timely data, having it in the areas where you want to incentivize is something that many organizations are finding that's what's holding them back, is getting data that everybody can be comfortable with and apply. That data needs to be easy to track and understand for the physicians. Physicians, will be responsive to performance. They want to be, they want to deliver high quality. They want to, they are by nature, by and large, competitive. If you can give them data that's timely, that's accurate, that's applicable to what they're doing, and they understand the mechanisms, they will find a way to optimize that. If it's buried in a black box or if it's unclear, you're not going to get the traction that you want to get. Obviously, matching those incentives up and the compensation structure up to the actual goals you're trying to achieve, whether that's how you're actually going to be reimbursed or strategic goals or other metrics, it's difficult. And most organizations are experimenting with how to do that. And they will try one approach, and if they don't see the direct results, then they go back and they try another approach. And that sort of idea that, we're figuring this out as we go is just the reality, which again is a challenge. It's a challenge that we just acknowledge and we don't necessarily have an answer for. At the end of the day, the number one question is, how do we continue to compensate physicians appropriately to recruit and retain them? The conversations that we've heard recently, particularly from physicians in the market, as they look at the looming implications of MACRA and MIPS and other things, is real concern about ongoing threats to their compensation, ongoing threats to their income that's going to bring it down. And so, while it's nice to have guaranteed comp, while it's nice to have annual increases, the reality is that for many physicians in this new world, that's not the reality that they're looking at. So how do we manage them? How do we manage that in the context of keeping a physician enterprise that's complete enough and performing well enough that it supports the organization, whether that's financially, operationally, quality, or otherwise, is a delicate balance. And then lastly, and probably obviously, is how do we continue to do this in a way that doesn't go awry relative to federal laws and other requirements, and making sure that we've always got that question in the back of our minds, because the penalties for that could be just as significant, if not more so, than the downside of poor compensation planning and the impact of physicians. So that was our presentation for today, and like I said, we wanted to leave time for questions and comments from the group. You should be able to do that through the interface, and I think we've got a couple already teed up. If you do have something in mind, please submit them, and we'll do our best to get to them today.
Thank you to all the presenters. As Todd mentioned, we have some questions received, but we encourage everyone who has a question to send it to us through the listener interface. One question we received is whether any of the speakers has seen an example of an organization that has taken value-based compensation metrics and simply added them to the existing productivity-based metrics rather than substituting some metrics for existing metrics for value-based metrics.
Well, I'm happy to take the first stab at that. That's where a lot of organizations start because, you know, effectively a good way to describe that is an upside-only approach to add, you know, a way to incentivize physicians. And so let's take some of these performance metrics, get them socialized with the physicians, start to build our own infrastructure for measuring and communicating them. But let's not make it be a situation where we're going to penalize the physicians, but let's give them the opportunity to work in it and perform and you know, have upside only, if you will, benefit. And that's in some ways how the actual reimbursement program started as well, is, you know, let's do this as an upside only approach. The challenge then, or, you know, the next evolution of that obviously is then how do we make that transition to put more and more at risk? And you know, that's where most organizations are right now, is moving into that. It's not just upside, but there is actual risk to poor performance, and how far and how fast do we go to that? So the short answer is yes, absolutely, we've seen it, but it needs to be done in the context of how do we move to that next evolution.
Also, I'd say the speed that we move to the evolution. It's how fast can we get from where we are today to where we're going to need to be tomorrow to balance that budget of money coming in and money going out.
Mm-hmm.
All of the speakers emphasize the changing nature of compensation in this environment, and in particular the idea that there's a learning that is going on and a testing of different approaches. And one of the listeners is asking, is questioning whether physicians will accept the idea of compensation approaches changing every year, every 2 years, or more frequently, and how you deal with potential resistance to that.
Well, I can start by saying that in my career, when I was involved in establishing physician compensation programs, the joke was that every organization has 3. They have last year's, this year's, and next year's. So I think that they've all been an evolution as we've aggregated compensation plans to multi-specialty groups, or to clinics, or to employed physicians over a broad range. And I think that there has been change that started. It started slow. The change is more rapidly, and I think those organizations, as I think Todd said before, those organizations that have already started are going to be ahead of the game as it comes to making that aggressive change that will come when the payment structure from payers, government payers, and private payers really changes and includes a downside part of compensation.
Excellent. Dr. Pryor mentioned the idea of committees to assess the validity of potential metrics used for compensation. How do you determine what physicians would be on those committees?
In my experience, it's good to start with a physician leader who is a well-established, well-respected clinician first, and have this as your chairman of the committee. Because as you start getting involved in pay for value, there's the value that's returned to the patient, which is the most akin to what we physicians really want to do at the last. How do we add value to the people who see us? And physicians are in the best position to look at this vast array of all the metrics that we can measure and say, you know, this one right here is pretty bad, but these over here really make a difference to our patients. So let's start by focusing on what really makes a difference to the patient, which in turn will add value to the population as a whole.
Another question received, which is, what is an acceptable spread between the compensation percentile and the productivity or revenue percentile?
Well, revenue is easy. If you don't have a subsidy, it has to balance. So from the revenue side, and this is one of the things that always used to drive me nuts, is I had to know how much money the clinic had coming in versus how much money I was going to pay out for all the various things that we paid for. So revenue is a pretty easy deal. Unless you're subsidized, it has to balance at the end. Productivity is different, and as we turn the dials up on value-based purchasing and down on productivity, this also has to correlate with how are we being compensated and how well are we hitting the relative values, different than RVUs, but the relative value that the payers are going to compensate us for. So as we add value to our patients, how do we get compensated for that? And again, unless you're subsidized, at the end of the day, the money coming in, the money coming out have to balance.
This is Jim. I would just add one other thing. Is as you're looking at your survey data, because that question references, the percentiles, probably off of one of the salary surveys, is, whether you're an independent clinic or an employed group, your payer mix may be different, and your payer contracts at their relative, levels compared to Medicare may be different as well. So one of the first pressure tests you should do is run the net collection for work RVU for your individual group against what the benchmark data shows, because one work RVU is not equivalent to another when reimbursement can vary by as much as 50% across markets. So at a minimum, you should do that as your first filter before you get to the very specific metrics that Dr. Pryor mentioned.
Thank you. Another point that was made is the concept of matching compensation to strategic goals. And the questioner is wondering if you have an example of what that might look like.
Sure, this is Jim Pizzo. I can jump in here. An example would be is if we're going to open up a new site, it would be unfair to the physicians who are put in that new site to expect them to be at median or higher productivity within a year to 2 years, depending upon how high of a growth site that is. So what you want to do is have something that comes in, a payment where they're either credited with work RVUs or some level of enhancement to their base to get them to be willing to go and grow this site out. And you don't want that incentive to be in place too long, or you won't have the incentive to continually grow it out. But if you're going to ask a physician to start either a new specialty that maybe your organization didn't offer before, or move to a new site, that's one way you could look at it. Another would be outreach. So a lot of organizations out there are asking their physicians type. The federal government does not like windshield time being paid for. So that's when you could have a strategic incentive, and you have to basically tie it to the community benefit that you receive by having your physicians go out to maybe some of the more remote or rural sites. And that's become a big issue for the health systems out there, and even the clinics who are in more rural areas, is you still need to provide care in the appropriate setting and the most cost-effective setting. And many times that means getting your physicians out of the main site and into some of these remote sites. And to do that, it wouldn't be fair to them from a compensation perspective to expect them to be at the same level. So that's when some sort of strategic support would typically come into play. There's probably 1,000 other ways we could spin it, but it's really when they're doing something for the benefit of the health system or the large clinic that will potentially negatively impact both their productivity as well as quality, access, and service metrics.
Thank you. We have another question that mentions the triple aim and asks about this concept of balancing payment between PCPs and specialists and aligning that with the goals of the triple aim. And the questioner is wondering if any of the speakers would like to comment on that.
Well, first of all, the amount of waste that we have in our systems is at least 30%, and part of that waste comes in the guise of overproduction. So as we try to reduce the waste and reduce overproduction, some of this is looking again at what is the appropriate way to handle a given, or not maybe appropriate, let's say acceptable way to handle a given condition. So again, this goes back to the use of good physician committees that say, here's the evidence-based practice of how we would like our group or our clinic to practice within this range of the existing evidence-based metrics. Now, again, there are not a lot of evidence-based agreed upon metrics, but there are some, and you can start there and move on. But that's, if you go back to the evidence, that's the best way, I believe, to look at which is truly overproduction and which is not.
And the key here, too, is, you know, as we advance on triple aim goals and utilization and overproduction, as Dr. Pryor mentioned, is affected, that's going to disproportionately affect specialists, and within that, certain specialists. So that's where the intersection of the compensation planning and the strategy happens with medical staff planning, and having a long-term view of that and understanding that there's going to be certain specialists that from a productivity standpoint might be harder and harder to support, and you're going to have to think of other ways of providing those services and compensating those physicians if the utilization and that over-productivity, as Dr. Pryor said, is worked out of the system.
The final question for today is probably a good one to close on, which is the presentation has so much complexity to it. It really reflects something that is very daunting for organizations to get started with when it is something new for them. So what are some good and critical early steps to get started?
Well, I think the earliest step is to educate. And as I talk to other physicians, some of them are very, very facile at talking about this. Some are just getting their feet wet, and some of them still have no idea of what's coming down the line. So I think the first step is we need a broad-based education of here's where things are going. The cheese is being moved, but here's where it's being moved to. So I'd say that would be the first step.
Well, thank you very much to all three speakers. Thank you very much to the participants. You will be getting a follow-up email with information on how to access this presentation. In addition, please note on your calendars that we have another webinar in this series coming up on Wednesday, October 5th, New Era Metrics for Physician Performance. Thank you very much on behalf of the speakers and Kaufman Hall, and have a wonderful day.